Hi, thank you very much, Dr. Osha, first of all, to give us the opportunity to be here. Trabectome is a micro-incisional glaucoma surgery for adults and children based on an invention of Dr. George Baerveldt. It's somewhat similar to phaco, but of course treats the surgical site of glaucoma, which is a trabecular meshwork. We are here in Sarasota for Telling It Like It Is. We found our booth, we know where to go for setting up our wet lab, and that's what we'll go do next.
What we're going to do today is talk about the trabectome microincisional glaucoma surgery. It's really one of the very first MIGS procedure, the microinvasive glaucoma surgery. We'll talk briefly about the technology and background, angle anatomy, which is really critical to success in this procedure, some of its features, surgical steps. We'll show you some video as well, and then we'll look at some of the data, and then lastly we'll kind of work into the wet lab portion of the program.
One of the biggest challenges that I find in the field is not knowing the anatomy as well as we should, landmarks at least. So you're going to basically go and essentially use the techniques that Steve mentioned, and we'll walk you through that to basically incise the inner wall.
This is one of the most refreshing meetings because speakers, they tell it like it is.
Oh, I thought it was very informative. I mean, I love the fact that they started off with a didactic session. It's a good experience because unless you kind of get your hands on it, you really don't appreciate the feel. And I was also able to appreciate when I was doing it right, that there was very little resistance, and it was almost like a sweet spot that I was in. And you can't teach that. You gotta have to feel it.
Once you get that sensation and feel it, it actually works very well.
Hardest thing for people to start to do when they first start doing trabectome is sort of mentally understanding the neuromotor patterns and how your hand has to move in space, making sure that you're moving enough in each of the planes appropriately. I think that was really the hardest thing for people to learn, but they picked it up pretty quickly.
This is exciting as another adjunct for someone to have a less destructive procedure than, say, a trabeculectomy or something like that.
Trabeculectomy has been around for a long time, and we know a lot of the good, and we know also some of the baggage. This is the gold standard procedure, lowers pressure significantly, but it's not physiologic. It certainly has been associated with numerous early and late postoperative complications, and the lack of predictability is always something that's a challenge. So, it had this role, and it still has a role. But certainly, if we can move towards something that is more physiologic, that is a reduction in safety profile, that's what we're after now. We're not there yet. I think we still have a long way to go. I think that the new devices in this space called MIGS, I think is a step forward. We're learning from it.
My name is Vold, and I've been using the trabectome since I believe August 2007. And at that time I introduced to the technology, and one of the things I was very excited about is that it restores physiologic outflow. And it really was a minimally traumatic procedure. And it's been something that's been a part of my procedure, armamentarium for treating glaucoma since that time. One of the exciting things about this is, again, we don't have a filtration bleb. Patients recover very quickly. And especially in the setting of cataract surgery, I've found it to be a very effective way of lowering intraocular pressure and also getting patients off their glaucoma medication.
I'm mainly a cataract surgeon, so I tend to refer complicated cases out, but I think this will bring it back in.
It was wonderful to be able to actually feel the procedure being done in my own hands. I felt really comfortable about it, and I think it would be a really nice addition to a cataract surgeon's practice.
My interest stems from trying to look at newer ways to treat glaucoma, medications being problematic for many patients, and combining this with procedures like cataract surgery that we know have high efficacy.
As a glaucoma specialist, we've been trying to avoid filtration blebs for a long time. A lot of times comprehensive ophthalmologists and cataract surgeons have really not, when they have a patient with glaucoma and cataracts, they really have kind of left the glaucoma alone. This allows the comprehensive eye surgeon to really better take care of their patients. I will tell you, in the hospital setting, this tends to be a really well-received product because the reimbursement is really quite good. It's a very well-established code, which is very important. This is really a quality of life situation for my patients, and so I think making that case is really important. The trabectome has really been a leader in this field for a good number of years, and the excitement in this area is really growing every year.